this computer. Okay. So welcome back once again to this program of bioethics, and this particular course in the bioethics of end of life, at the end of the human life. Beginning always with a little prayer in the name of the Father, the Son, and the Holy Spirit. Blessed Trinity, we love you, we adore you, and we thank you for your many blessings, for the gift of life, for faith, hope, and charity, and for having us here today, Lord, once again, to delve deeply into these issues of human life, especially toward the end of human life. So many decisions that need to be made there, Lord. We know that with your inspiration, with your guidance, we can make the right decisions as you call us to go through that process of death so as to live eternally with you in unity with all the angels and saints. We praise you, we love you, and we thank you for all the many blessings that you give us. Especially during this time, we continue to pray for those who are in most need of your divine mercy. In the name of Christ, our Lord. Amen. Okay, before getting into the subject matter of today, any questions or comments, anything from before? No? Okay, we're going to move forward. Just a very brief summary of the previous two lectures. First, we looked at the issue of human life, organically speaking. What maintains us alive organically is our vital organs. Vital organs, and we can list them, 6 to 8 vital organs that we have in the body: the brain and the brain stem, the lungs, the heart, the kidneys, the liver, the intestines, the pancreas. These are the vital organs that keep us alive, okay, on a regular basis. And so when the process of death begins, somehow these vital organs are involved or failing, either one or several or all of them. But we understand that because they're made up of trillions of cells, they don't all die at the same time, okay? And that is the challenge that we find toward the end of life, defining precisely when the person is dying or when the person has died, is that these vital organs don't all die at the same time. And then the one organ that integrates the others, of course, is always the brain, but we include the brain stem because that has the function of maintaining the involuntary movements of the body, the metabolism, particularly respiration and circulation. Then we talked about the unconscious states, various unconscious states. The one that will concern us the most existentially will be the persistent vegetative state, or PVS, or just vegetative state as is known typically today, because the person is unconscious, maybe with some support of life-saving machines, of life support. And then the question is maintaining, should we continue with this vegetative state or not? Okay. So that's one that is the main issue many times today. Also because we find an increasing number of people dying in institutions as opposed to at home. I think maybe about 2/3 of the population in the United States today dies in some kind of institution as opposed to dying at home. And that complicates the issue because now there's an institution involved, there's insurance involved, there's a clinical setting of some sort, there are regulations that kick in, government agencies and so forth. And then there's typically a third party taking care of that person, of that dying person. So this is something to note, and it's of concern that fewer and fewer people today are dying at home, all right, surrounded by their family and friends. And that's a phenomenon mostly of the Northwestern Hemisphere. It's kind of ironic that these are the nations that have a better standard of living and more well-being in general, talking about Europe and North America, and yet fewer people are actually dying in the arms, literally, of their loved ones. All right, so it's challenging. All right, so now we're going to go into the determination of death, clinically, legally, and bioethically. All right, and hopefully those three realms coincide and are in agreement when death occurs. And then we're going to look at means of life support, ordinary means and extraordinary means of life support, the big topics for today. Moving forward then, let's look at the determination of death. First, we start with a legal definition that, thank God, coordinates and incorporates the medical experience, the clinical experience of the death process, okay? This is a model that became an act of the United States. It's called the Uniform Determination of Death Act, that is being promoted state by state, because interestingly, each state in the Union has the right to establish its own criteria for death, for issuing a death certificate, which has legal implications. Just think of inheritance, for example, or when a funeral home can actually bury someone. A funeral home cannot bury a cadaver without a certificate of death, all right, or a declaration of death from the state. So it has a lot of legal implications. And up until the mid-1900s, there was no uniformity between the different states on how a person was actually declared dead. Most of them followed some kind of a clinical guidance, of course. It was left to the medical doctors, but there was no uniformity. And so in the 80s, there was actually through the 70s, for over a decade, there was a movement mostly by the commissioners of different states, okay, state commissioners that have to do with legal issues that have an impact on society. And these commissioners, they're counsel to the state governors, and they decided to try to get some kind of a uniformity, a uniform declaration of death across the states of the United States, okay? And that is this, what is the acronym UDA or UDA, is a Uniform Determination of Death Act, which, like I say, is being put through legislation at the state level, It's interesting that the federal government doesn't interfere in this aspect of state governance, all right? So it's been proposed as a model law, and it has been approved by the majority of states in the United States up to 1981. Like I say, it was put together by this Conference of Commissioners on Uniform State Laws, and also with the consultation of the American Medical Association, the American Bar Association, and therefore it has a lot of weight. This would be like the standard protocol that these agencies are recommending. It is also in consultation with a commission, a President's Commission on Ethical Problems in Medicine and Biomedical and Behavioral Research. These are all bodies of consultation. This last one at the level of the US President. Okay, so it went to that federal level, if you will, because, you know, the White House, the President, and his or her cabinet is in charge, is the executive branch of government, is the one that is in charge of enforcing the law, right? legislation at the federal level is Congress. In other words, the ones who design and craft laws is Congress. And then the executive branch, which is the White House, all the way down to all the police departments in every state and every county, that is the executive branch in charge of enforcing the law, whatever that law is. And then judicial, of course, is when there is a controversy and there is a question whether something is legal or not, vis-a-vis the Constitution, what is permitted by the US Constitution, then that's the Supreme Court at the federal level. And parallel, most states parallel that system, whereby there is also a state Supreme Court that decides with regards to the state constitution. All right? Yes.
So in summary, it's a collaboration of the National Conference, the AMA,
yes,
and the President Commission,
yes,
whereby this came about.
Yes,
okay.
Yes, yes. So you can see that it has a lot of force, you know, it has a lot of weight, because all these are professional agencies that represent different aspects of our social life or civil life in the United States. And specifically, the determination of death, these are the 2 points. Either one of these is applicable for declaring a person dead. Either irreversible cessation of circulatory and respiratory functions, in other words, no breathing and no heartbeat, okay, no breathing and no heartbeat together, or irreversible cessation of all functions of the entire brain, including the brain stem. Okay, and so it can be either one of these two. And you notice the redundancy here, especially on the second criterion, because this is a new criterion, if you will. The traditional classical one has been the no heartbeat and no breathing. But this new one is the neurological criterion. Just wanted to point out the redundancy, the 3 layers of redundancy here. First of all functions of the entire brain, including the brainstem, in case someone was not clear. All right. So you notice all the redundancy that is built into that particular statement, because we're talking about dead or alive. Mm-hmm. All right, so let's look at these 2 criteria a little more in detail. The first one is called the standard criteria, or the classical, traditional, also known as the cardiopulmonary criteria. And it has 2, again, no heartbeat and no breathing. The other one is known as the criteria. And so for the first one, typically no instrumentation is necessary. No instrumentation is necessary. In other words, it's sufficient to feel for no pulse, all right, and for no breathing. Sometimes, particularly in the past, clinicians or others would use a little mirror in front of the nose, right up to the nose, to see if there was any faint breathing. What would happen on the mirror? What would happen on the mirror if someone is still breathing a little bit? What would we see? Would we see something on a mirror? We put a mirror up to the nose. We would see clouding. We would see water vapor, because we exhale water vapor. And that vapor in contact with the cold glass will condensate, will condense right away, and will generate a little cloud of vapor. Right? And so sometimes a mirror was used that way, or for the heart, a stethoscope, which listens to the heartbeat in finer detail. But the point is that typically for this criterion, no instrumentation, or at least no sophisticated instrumentation, was necessary. The neurological criteria is a different story, because now we're looking at the function of the brain, which is a biochemical function. There's no movement of the brain as such when the brain is functioning. It's rather an electrochemical activity that is occurring primarily at the cortex, but also within the brain itself and also the brainstem. And so typically what is used is known as an electroencephalogram or EEG, which measures electrical currents going through the brain, all right? And so what is not acceptable is a partial brain death, and this was in discussion in the 70s and even into the 80s, but partial brain death would only include what we know as the brain or the cerebrum, the two hemispheres of the brain, cerebrum. Thank God that did not pass. It's not acceptable. What is acceptable is total brain death, again, just emphasizing that the brain stem, which is also known as medulla oblongata in the medical profession, and it's a name from the Latin, which includes this bulb here called the pons. All right, the brain stem controls the autonomic nervous system or the involuntary functioning of the body. But that involuntary functioning of the body precisely is vital functioning. I've mentioned already several times, a heartbeat, all right, so that is essentially circulation, and also breathing, respiration, mostly by moving, so respiration is interesting because it has two different sets of muscles that move the lungs, that expand and contract the lungs. The lungs act as, if you think of it simply a balloon, but a balloon that is attached on the outside. And if we move the outside of the balloon out or in, then we are able, if we move the balloon, the surface of the balloon out, we are essentially inflating the balloon. What's going to happen? The balloon is going to suck in air, right? But if we compress the balloon, then the balloon will exhale, will release air. And that is what happens physically in the breathing process of the lungs, of the 5 lobes in the lungs that we have. How is that movement achieved? How is that expansion and compression achieved on the lung without actually touching the lung or without having muscles or bones attached to the lungs themselves, because the lungs are delicate organs, all right? Well, it happens by the rib cage, but also by the diaphragm. And so the rib cage is, the ribs are connected with little muscles called intracostal muscles. And if you ever go to Tony Roma's or you like to have spare ribs, that's what we're eating is the intracostal muscles, which are very tasty, right, when they're cooked right. So let's see, rib cage here. Right, so this is going to give us the skeletal structure. Okay, here is some of the muscles. By the way, in the rib cage, the ribs themselves also produce a lot of red blood cells. Okay, they produce a lot of red blood cells, and that's why breakage to the ribs may bleed quite a bit. But essentially, I was looking for one that had the muscles attached. Let me see if I can find rib cage and muscles. Intracostals. Oh, okay, intercostals. Yes, they would be intercostal. Sorry, not intracostal. In between. There we go.
A little bit off topic. And the rib cage, tell us if it's male or female.
Well, by the lower ribs over here, by the last rib, which I think this last rib is detached in the woman. All right, it may be associated with birth, giving birth. I don't remember well, but is what's called a floating rib, and I think it's women.
So the woman is basically a floating rib, or is the man?
Yeah,
Yeah.
let's look at that because I can't remember exactly, but let me look at that in a minute. Let me stay with the topic for a moment. See how the muscles are actually attached to the ribs, okay? So these are called skeletal muscles. We have three types of muscles in the body, three categories. We have skeletal muscles or structural muscles, the same. And then we have smooth muscle, and then we have cardiac muscle. Now, the cardiac muscle is only one, and it's also known as what? As the heart, okay? So that's the cardiac muscle. There's only one cardiac muscle in the body, and that is the heart. And its particular characteristic is that it has a self-beating pulse, the muscle itself, in addition to being wired by nerves to reinforce that beating motion, that constant beating motion, minute after minute for years, for decades as we live through life. But I'm going to concentrate for now on the skeletal muscles or structural muscles. And skeletal muscles have a couple of characteristics. Physically, anatomically, they are connected to bones. Skeletal muscles are connected to bones, all right? That's what makes them skeletal. They're connected to the skeleton, and they're connected through tendons. All right, so tendons take the tension, if you can think of it that way. Tensions connect muscle to bone, and they take the tension of the contracting muscle. As the muscle contracts, the bone is moved, all right? And so skeletal muscles are connected to bones by tendons, and those tendons are the ones that break when there is an excessive stress, and then it takes time for healing and so forth. They can heal, but it takes time.
NFL players.
Yes, of course. So the athletes have to be very careful about this because they're putting a lot of stress, more than normal stress, on their skeletal system. But also, skeletal muscles are connected to nerves. All muscles are connected to nerves, and but the skeletal muscles are connected to voluntary nerves. They're connected to what we call the central nervous system, precisely the brain and the spinal cord. All right. But the skeletal muscles are connected to the central nervous system, which is also the voluntary nervous system, which means that we have control over moving most of our skeleton. So again, the classical, I am thinking I want to move my arm, and I can send that thought, if you will, as a nerve impulse to a muscle that is connected to a bone in my body, and I can move the arm, I can flex the arm, and that's precisely the biceps, a very known muscle, is the one that flexes the arm, all right? And so that is a voluntary movement through the central nervous system to the skeletal muscles. The intercostal muscles are skeletal muscles, and therefore we can move our rib cage voluntarily, right? And you notice how the rib cage is, when the rib cage is relaxed, it is facing downward somewhat. It has a downward drop, if you will, a downward bend, all right? That is when the rib cage is relaxed, it has this downward bend. But that's when the intercostals are relaxed. But when we send the signal, breathe, inhale, specifically inhale, we contract the intercostal muscles. We contract them, pulling up the rib cage, okay? And as we pull up the rib cage, we also pull it up and out because of the bend, because the ribs are bent. And so there is an up and out motion like that, which has the effect of expanding the lungs. All right, so it's all a very mechanical thing that we can control, and we can extend our rib cage by contracting these intercostal muscles. And that inhales, so the inhaling actually is an effect, it's a side effect of opening the rib cage, all right? And we are expanding the lungs that way, and so that the air is drawn in. So it's not that we're pushing air inside the lungs. We're not pushing air inside the lungs, all right? We're actually sucking air from the atmosphere. We're sucking air from the environment by expanding the rib cage and thus expanding the lungs. And then when we relax those muscles, then the rib cage is contracted and we exhale. Of course, in that interchange of air, we also exchange oxygen for CO2. That happens at the cellular level with the alveoli inside the lungs. So you can see all this to say that that is a voluntary motion, a voluntary movement, which you could say, well, if the cerebrum is dead, then, or unconscious, for example, then that movement is stopped, right? It's stopped. However, when we are asleep, we're not conscious and we're not telling our lungs, breathe, breathe continuously. We're not moving these intercostals voluntarily. But there is a second, there's a second muscle, which is the diaphragm. The diaphragm is like a dome on top of the viscera, on top of the stomach, and just below the rib cage. Okay, so diaphragm muscle. Okay, you see, it's like a dome here underneath the rib cage, and it bellows up quite a bit, all right, almost halfway into the rib cage underneath. Very interesting how it domes up like that. That is the relaxed position of the diaphragm. That is the relaxed position. Now the diaphragm is not a skeletal muscle, which means it's not connected to the central nervous system, but it is a smooth muscle. And smooth muscles typically are not connected to bones, not directly, all right? And secondly, they're not wired by the central nervous system, they're wired by the autonomic nervous system, which goes precisely to the brain stem. And the brain stem has its autonomic function. That's precisely why it's called that way. Other examples, there are many smooth muscles in our bodies. For example, the throat, a smooth muscle, the esophagus is a smooth muscle, has a peristaltic movement, has a wave-like movement of contraction, pushing food down. That motion continues actually through the stomach and down into the intestines, which are also a smooth muscle. The anus is called a sphincter, it's a circular smooth muscle. And all these muscles are not connected to bone directly, but they are wired through the autonomic nervous system. So they have their own automatic functions, if you will. They know what to do. It's all regulated biochemically by signals, stimulus and response, and so forth. Well, the diaphragm has its own movement that is controlled one way or another. It's affected by the level of CO2 in the body. And so actually in the brain. So if CO2 increases just slightly, that triggers a contraction of the diaphragm. The contraction of the diaphragm means that it's going to push down or bear down. The dome is going to become more flattened, right? Because it contracts down. As it contracts down, it is also expanding the lungs from beneath, if you will, but it's also expanding the lungs, and it has the same net effect as the intercostals or the rib cage, by the rib cage moving up. Kind of in contrast, it's interesting, the whole design of the rib cage is so interesting that when the ribs move up, the lungs expand. And when the diaphragm moves down, the lungs also expand. So if you consider the physics involved in the design or the evolution of the rib cage, it's very interesting and sophisticated. And also the wiring, if you will, the nervous wiring of it, part of it is through a voluntary system and the other part through an involuntary system. And what is the function of all this and the big picture is to secure what? Is to secure a constant breathing, precisely. It's to secure a constant breathing whether we are conscious or not. So there's a big safety mechanism, if you will, that is built in through evolution. In other words, the animals that develop this system, which typically are the higher animals, we're talking about vertebrates, okay? Then the ones who developed the system and the ones who developed it better survived and survived better, were not selected out because they did not asphyxiate to death, basically. So we have this dual mechanism for breathing, and that's why the brainstem has to be included, because the brainstem has the wiring for the diaphragm. Okay. All right, so that's the bottom line for this, and also the wiring that goes to the heart from the brainstem, which also guarantees that autonomic pulse. For that one, we really have no control. There is no known wiring of the cerebrum directly to the heart for a voluntary control of the heartbeat. Okay, so that one has been automated totally, if you will, through evolution. Now, let's look at this a little more theologically before we do the actual bioethics, but at least theologically, what is involved here, the dying process. Because one thing is to look at it clinically, or first biologically and then clinically, all right? But now let's look at the other angle, if you will, which is theologically, at least for people of faith, and for people who believe that there is a human soul, and there is a human soul for all humans, even for those who don't believe in their own soul or anybody else's soul. And the characteristics of that soul, some of the characteristics, at least that we can intuit theologically by doing theological reflection, is that the soul is individual, personal, simple, has no parts, okay? And also eternal, or if you want to be a little more technical, semi-eternal, in the sense that it has a specific origin, but no end as far as living eternally, right? But it does have a finality. So when we talk about no end, we have to think in what terms that phrase no end is not univocal. In other words, we can interpret no end as having no purpose, or no end as living eternally, all right? And it's in that second term, in that second meaning, that I say that the human soul has no end. Anyway, these are some of the characteristics of the human soul. And further, we believe that we have been created to live eternally with God, all right? And so that helps us, those beliefs help us at the end of life, precisely to not despair, because like they say, the popular saying, right? Two things that we can be very certain of on this earth is death and taxes. And even if we manage to avoid taxes somehow, some way, we're not going to avoid death. Okay, so
if Trump passes, we will pay no taxes.
Yeah, that's right. Let's see what happens. Then he'll narrow it down to one, and then let's see if he can avoid that one. So far, no one has done it except two people here on earth, right? Jesus and Mary. But you can see that the faith is very, very important as we are alive, thanks be to God, and healthy and thinking now, to think about these thoughts, because someday it's going to come to us. And before it comes to us, typically it has come to a number of relatives and friends and people around us, even strangers. It happens that we're 4 clergy today in the class, and I'm sure we've dealt a lot with dying people and dead people and then their relatives and friends. And we know the anguish that can occur there existentially, and all the pastoral healing that needs to occur, that can occur. They are moments of grace also, where conversions can happen. And the typical thing, okay, so again, based on the norm, what is the norm? The norm is that we bury our parents, right? Just like they buried their parents and so forth, because of the chronology of life. But when that process reverts, and we have parents buried in their children or their grandchildren, that's a tragedy, humanly speaking, and I'm sure we've all been involved in the premature death of some people and how the family copes with that, right? And relatives and friends. To me, there's nothing more distressing than the funeral of a teenager, okay? Either because of illness or accident or whatever, drunk driving, you name it. But I'm sure we've all been involved at the funeral of a teenager at some point, and it is just devastating. And we see the whole range, the full range of expressions and emotions and sentiments going on, from total acceptance to total denial and everything in between. Okay, one time there was a funeral. A teenager happened to be at a huge public school in the West Kendall area, and there was a gang thing that happened, and the two gangs showed up. The rival gangs showed up at the church for the funeral, and they practically got into a fight in the middle of the mass, in the middle of the funeral. It was just, I mean, Fellini would have had a ball filming that and making a movie out of it, because it was just unbelievable. So the full range, dealing with the parents here who are totally destroyed and grieving the premature death of their child, and then other people, relatives and friends, even media wanted to come in because it was such a shocking thing. And then you got the gangs who are trying to fight each other out there. It was a real scenario. Okay. Now, and I'm thinking in my own mind, if these people had some kind of faith, first of all, we probably wouldn't be here today. And secondly, if we were here, it would be a very different scenario. Okay, a very different scenario. So I cannot emphasize enough how important the faith is at that moment. And we who have it by the grace of God have that responsibility and that privilege to try to share it with other people. But in the moment of stress, in the moment of anguish and grief, how to do that, right? It takes a lot of refinement and humility and patience, not to beat them over the head with it either. We have to be very careful. So to be clear on some basic principles in theology, and this actually goes into what we know as fundamental theology. We know, you all know as training even from seminary time, that human life is a fundamental value, but it is not an absolute value, okay? It is not an absolute value, like, for example, the Trinity is an absolute value, where there is no negotiation there. All right. But human life, it is a fundamental value, but not absolute, in the sense that human life is going to end sooner or later, organically speaking. All right, and that could happen anywhere from the zygote stage to 110 years of age, whatever these old folks up in the Himalayas that drink the yogurt and all that, right? Remember that there was one time some kind of an advertisement of some old men sitting around on a rock up in the Himalayas and talking about, oh yes, how delicious the yak yogurt that they were eating, and they were very old men, and they were very happy about the yak yogurt that they were eating. And they're saying, oh yes, and you should see our grandparents eating this. They like it too. These were all, they're talking about their grandparents. So it was kind of a funny thing, but some people can live a long time. The point is that no matter how long we live, sooner or later it's going to come. So we need to realize this, that we cannot cling to life here organically as if it was an absolute value. Okay? Very important, that distinction. We can help the laity make that distinction, because I can tell you, I'm sure you've experienced it, they're not clear on the fundamental distinction between these two things. Okay? Delving a little bit more on fundamental, what is fundamental? Basic, right? Basic doesn't mean absolute. I say the distinction between fundamental and fundamentalism is fundamental. Okay, it's a basic distinction between something that is fundamental, that is basic, and fundamentalism that becomes a narrow-minded acceptance, for example, of the literal interpretation of the Bible, which is not the true interpretation, not intended that way. So the ism, the problem is in the ism, you know, it's an exaggeration. Okay, moving forward then, you get the point. For the United States, anyway, today, these are the numbers. The life expectancy in general is 79 on average, but if we break it down by the sexes, we have 81 years of age for women, 76 for men. What's a little disturbing about this is that little by little, this average age for women has been creeping up, and this average age for men has been creeping down. Okay, and again, typically the number one killer is heart attack for men, stress, and just the unrealistic expectations of a society that becomes more and more accelerated, more and more complex, and the pressure that that generates on the man. So these are the numbers, and we have to take note of that, because one way or another, we're the ones who make society, you know. It's not the plants or the rest of the animals that live here. We're the ones who are making this society and are putting this pressure on each other one way or another. So the challenge is there, and a lot, we know, has to do with the economic system and so forth. But some of it not. Some of it is actually cultural. This Pope Francis has a little phrase in the environmental encyclical, Laudato Si, he calls it the rapidation or rapification, rapid. Everything has to be fast, quick, okay, instantaneous. All right, some other basic concepts that are important to define here as we continue to drill deeper into this topic, and death and the circumstances surrounding death. When there is pain and or suffering, we manage the pain, we seek to relieve the pain, all right? And we make a distinction between pain and suffering. Even though, even in the medical setting, you'll find medical doctors in the clinical setting don't necessarily make this distinction between pain and suffering. They use the term interchangeably, and yet, strictly speaking, is not fair, because we may address the pain and not the suffering, and vice versa. In other words, pain is more at the physiological level. Suffering is more at the psychological and or spiritual level, okay? Whereby some people can be in pain, even in tremendous pain, and not really being suffering. For example, the martyrs and saints, and vice versa, they can be in tremendous suffering and anguish and no real pain as such in their bodies. I give a simple example. The married couples who is having their first baby, and she's in labor, and he's next to her, and so she's definitely in pain, but not necessarily suffering in the sense that she's happy about finally giving birth to their first child. He is suffering because he sees her in pain, but he's not going through any labor, so he's not in actual pain, but he's suffering for her. Okay, so there's a contrast and a distinction there. And frankly, I wish that the medical profession would pay more attention in general. It's just my personal experience from dealing with doctors, because, you know, pain can be treated with analgesics, but suffering can be treated with the psychologist or the priest or the chaplain, or it takes different professionals and different protocols really to deal with one or the other.
So far, in essence, there's really no scientific management of suffering, and there's nothing that you can prescribe per se.
Well, there can be, yes, because, you know, some drugs are what I call psychotropic drugs that have an effect on the brain, and this is again another one of those complementary dualities or systems, dual systems that work together, the brain and the mind, right? The brain and the mind. The brain typically is more the organic functioning of the brain as such, but that is a substratum for the mind to think and feel and everything else. And yet thinking and feeling are also abstract concepts, right? And realities, but they occur in a biochemical environment. But we can say that there can be some degree of suffering, but it takes a little different type of protocol, all right? But we are involved in that healing process. Many times they do come together, and many times relieving the pain also relieves the suffering, even of either of the person or the patient or the next of kin. Okay, another distinction to be made is in the analysis of this pain management or suffering management or suffering relief, what are the benefits and the burdens? So the benefit burden analysis, all right, benefit burden analysis, that ideally will be done by the patient as she or he is dying, but may need assistance from the caring people and the professionals to help them decide and see how does this balance out, all right, between the benefits and the burden of a particular procedure, especially when these procedures kick in toward the end of life. How, if intubate or not intubate, what are the benefits, what are the burdens? If to do CPR or not, to resuscitate or not resuscitate. Okay, I'll talk a little more about these as I give particular examples. Another important, two more terms to be clear on, the diagnosis and the prognosis. Because again, these have to bear with this management, the analysis of the benefit and the burden. The diagnosis is the current state of the patient, clinically speaking, right? And until there is a diagnosis, really there's no treatment, because what protocol are we going to apply? Does it involve antibiotics? Does it involve intubation? What are we talking about, right? So the diagnosis is critical, and again, it's the medical profession that determines the diagnosis, organically, clinically speaking, with the patient. Then the prognosis is the hope of recovery or not, right? The hope of recovery or not. What is the outcome? What is the expected outcome based on this diagnosis? So it's a stepwise thing. For example, first comes the examination. From the examination, the doctor hopefully arrives at a diagnosis, which is certain and true. And then diagnosis will lead to a protocol that either there's a standard protocol for this, renal failure, dialysis is the protocol, all right? That's the standard of care, or the standard clinically speaking. But then what's the prognosis also? Depending, is there a hope of recovery? Is the hope of recovery good or poor or practically nil or excellent? You know, we have to go patient by patient, right? Because the complexity of the patient, and if there are comorbidities are other things that are going on. For example, the patient can be on renal failure, but the patient also has pancreatic cancer, all right? And so comorbidities are all the illnesses or diseases that are going on the periphery, if you will, of the main event of the patient. All right, let's move forward then now. Let's try to put it all together into the bioethical analysis, meaning we're going to draw from the biological and the clinical setting, but we're also going to draw from the theological and philosophical setting to come to some actual bioethical conclusions, value conclusions that will lead to certain behavior. We make the distinction between ordinary and extraordinary means of life support. Ordinary and extraordinary means of life support. Sometimes they're also known as proportionate or disproportionate means of life support, depending on what theology and what philosophy you follow. But basically they're interchangeable, nuancing aspects. The distinction here should be as clear as possible, because morally, ethically, ordinary means of life support obligate. They obligate morally ordinary means of life support. Whereas extraordinary means of life support do not obligate morally, ethically. They may be done if the patient wants, if there are resources, If the patient is unconscious, the proxy or next of kin or whoever is making the decisions, so on and so forth, depending on a number of circumstances, extraordinary means may or may not be done, depending also on the prognosis, big time, but they don't obligate morally, ethically. So extraordinary means of life support do not obligate, and that's very important. See how important it is, because nobody wants to kill the patient, right? Nobody wants to kill the relative. Nobody wants to disconnect grandpa and be the one who has killed grandpa. Well, we may be actually allowing grandpa to die.
Father, but there's a thin line between ordinary and extraordinary here.
There can be, if we're not clear. What we're trying to make here in this course is to make not a thin line, but to make a huge precipice, a huge chasm between the two, so that we are clear as night and day. You know, the light is either on or off. We're trying to make that case as clearly as possible. Okay, and I grant you that there will be sometimes cases that we're not exactly sure, is because we don't really have all of the information necessary, and we have not done the thinking process sufficiently, or the technology has become very, very sophisticated. But this distinction of principle has to be clear, at least in our minds. If we come to the conclusion that these means have become extraordinary for this patient, whereas the patient next to him or her, they are ordinary, the same procedure, the same protocol may be extraordinary for one patient and ordinary for another patient. You'll see a little more clear what I mean in a few minutes, okay? I'm going to give you concrete examples. But we have to be clear, at least in principle, at the level of fundamental principles, that ordinary means of life support obligate morally. Extraordinary means do not obligate, okay? We'll get to some concrete examples, and you'll see the 3 or 4 main ones. All right, so here is another layer of difficulty. That clinically, most medical doctors and the medical profession is not going to talk about ordinary or extraordinary means. They're going to talk about standard medical practice or experimental treatment. Okay? Standard medical practice or the standard of care or standard protocol versus experimental. If it's not standard, if it has not been standardized, in other words, if the protocol has not been validated over time in different places of the United States or the planet, then it's an experimental treatment, okay? So it can be that clinically the standard of care, again, is dialysis. That's considered standard of care for renal failure, but bioethically, it's an extraordinary means of life support. So these two worlds, or these two worldviews, do not always coincide necessarily. And we are bound to the bioethical one, because this is at the moral level. This other one is really at the technological level, where what technology allows us to do, what can be done, okay? Exactly. In fact, this is just kind of thinking out loud now, this is a good moment to make that distinction again. The clinical means of life support is what can be done with the medical standard today, here and now. And you can see that that varies also country by country, and that may vary region by region. One region of the US may have more resources than another region, more sophisticated. Why do people travel, to Mayo Clinic and to Cleveland Clinic and so forth, and to Texas, the heart centers that are there and so forth? Because they have more resources and they have standardized procedures that are more sophisticated. But this is at the level of what can be done actually technologically. Here in bioethics, we're involved at what may be done, what should be done ethically, yes or no, all right? So here we have not everything that can be done may be done necessarily. Okay, let's move a little bit further. Another distinction which I find very, very useful is the distinction between assisting or substituting vital organs. Did I send you the little article that I wrote on this in Ethics and Medics? I have not sent you that yet, no? Okay. It's a 2 or 3 page little article that I wrote a few years ago. I'll send it to you. Actually, it was maybe just 1 or 2 years ago. But this distinction is, again, one of these fundamental distinctions between assisting or substituting vital organs. And I say this in all humility, I don't find this discourse much among the clergy, let alone the medical profession or the laity, okay? I didn't really encounter it in the seminary years ago, and it was kind of indirect when I was doing moral theology at the Greg, at the graduate level. But since then, I've thought about it, reflected, and kind of refined it so that if we are able to distinguish with regards to vital organs, and this is the key here, we're talking about vital organs, okay? With regards to vital organs, are we assisting or substituting one or more vital organs, but at least one vital organ? Because by definition, vital organ is necessary for sustaining life. Any one of the ones that we keep mentioning. If that vital organ has begun to fail irreversibly, okay, it could be that the death process has begun. At that point, there is no obligation to substitute that vital organ. We may assist, and we should assist vital organs. If we have the technology and the wherewithal, there is an obligation to assist vital organs, okay? But we don't have an obligation to substitute the vital organ. When one is not clear on things like this, or it may seem a little, pushing the envelope, think of the reverse. Think of the converse. That's something that Aquinas used to do and taught us to do. When there is a theological or ethical principle that sounds a little iffy, think of the opposite and see if that makes sense to the intuition. Imagine if there was an obligation to substitute vital organs. Let's think about that for a moment. Let's say that there is an obligation to substitute vital organs. Well, every vital organ is going to fail sooner or later, right? That means that we would be obligated to substitute every failing heart, every failing kidney, every failing liver, every failing lungs, every failing brain. Is that sustainable? Is that realistic? Can that be done? Absolutely not. We can barely substitute a couple of the organs, a couple of the vital organs. The kidney is a classical one, and the pancreas maybe with insulin, but outside of that, the heart with a pacemaker or there used to be a heart-lung machine back then that actually forced breathing on the person. But if you think about it, it's not realistic. It's not sustainable to substitute vital organs when they're failing irreversibly, right? And therefore, it doesn't obligate. Therefore, there is no obligation to substitute vital organs. There is no obligation to substitute vital. Essential. We may want, if the patient wants, and if the patient wants to go into this experimental treatment or even the standard treatment, medically speaking and so forth, fine. If the patient is unconscious, then the proxy, no, they would want to be connected and keep on going, fine. But there's no moral, ethical obligation. Okay? Because at that point, we're actually dealing with some level of denial of the death process, whether conscious or subconscious. But we have to realize that there is an underlying denial of our death. It's part of what keeps us alive, wanting to continue living. There's a natural desire for wanting to continue living on a daily basis. And so we can assume that there's going to be an underlying substratum of a certain level of denial of death. Because sometimes the death process can be subtle, all right? Can be subtle, but real. And I'm thinking of the cancer situations where it starts like a little tumor in the brain or a tumor in the liver, whatever, and it starts developing and growing. Before you know it, there's metastasis. Colon cancer. Colon cancer typically has, well, if you take blood on the, fresh blood on the stool, but maybe has no other symptoms, there's no pain involved necessarily, and it's a very aggressive type of cancer. So we have to realize that perhaps the death process has begun and we're not fully aware of it. or we want to deny it. So this has to do with the basic question of when to withhold or withdraw life-saving treatment, all right, or life support system. Withhold, in other words, not initiate, or withdraw once it has been initiated. Life-saving treatment or life support system. Either not initiate the life support system or not continue it. Okay? Tough, difficult decision. Most people don't want to go there. The patients don't want to go there if they're conscious. If they're unconscious, their surrogate or next of kin don't want to go there. And the medical profession now has another layer of complexity, which is the legality of it all. Because the medical profession is going to be part of an institution, and the institution has what is called big pockets, right, or deep pockets, and then there's insurance involved. So we find today the predicament that a number of institutions and healthcare settings are going beyond or doing the extraordinary without even telling the patient or the next of kin, one, for legal reasons, for not getting sued, that they didn't do enough, but secondly, also because these procedures, they're getting reimbursed for it from the insurance. And so there's a double incentive, if you will. One is fiscal, the other one is legal, to keep people alive beyond, into their death process. And at that point, that actually is prolonging death instead of prolonging life.
Well, it looks like it's harder to die than to be born.
Yes, and it's getting harder and harder. And that's not even talking about the funeral arrangements and the funeral home and the expense, thousands of dollars, okay? And so people just can't afford to die.
Yeah.
So what are you gonna do? But it is, don't even get me started in the funeral homes because I'm totally enraged at what's happening. There's a conglomerate in Texas actually that is seeking to buy all the funeral homes in the United States and generate a monopoly out of that. Okay, and then they set the price. But they leave the local people in place. It's a little bit, it reminds me of the Roman Empire. They took over Europe, they took over the Middle East, they took over Northern Africa to the point that they surrounded the Mediterranean, but they left the local government in place, just like, for example, Pontius Pilate and Annas and Caiaphas and all the leaders, Herod, those were all local puppets that stayed in place, but it was the Caesar and the Senate that decided the laws for the whole empire. Okay, and it was a kind of a protectionism that was going on. So we have to be very careful with these attempts to institutionalize even the funeral process, where typically what loses out of the funeral arrangement is the mass. It's the mass, because the funeral home can't really charge for it. They should give the stipend to the church, but it's an inconvenience because it diverts them from the route. They have to dedicate extra personnel and time and effort, which then they don't get as much money out of that funeral, right? And the mass. And so we have people cremating or coming with the remains a month later or 5 years later, showing up with urns and ashes and a mass. It's getting a little crazy out there. Mm-hmm. Anyway, I've gone a little bit from the sublime to the ridiculous here, but I'm going to stop for a moment here, take the break a little early. Actually, it's 10:30 already. Break here, and then we're going to go into the actual examples of the most common issues at the end of life. They're going to be the three main ones: kidney failure, or heartbeat, or the brain, stroke, and so forth. Brain damage, irreversible brain damage. Okay, so we'll look at those. Let's take a break for now, and then come back in about 10-15 minutes. Okay, so let me pause this for a moment, and we'll be back briefly. Okay, folks, welcome back. After the break, we're going to continue with this lecture on the end-of-life issues, and essentially trying to determine and distinguish very clearly as possible the difference between assisting or substituting vital organs. In other words, how do we assess ordinary or extraordinary means of life support. It's again just summarizing the first part of this lecture. Ordinary means of life support obligate morally, but extraordinary means of life support do not obligate. They may be done if the people involved want to, but they do not obligate morally, ethically. Extraordinary means of disproportionate means of life support. Okay, so let's look at some examples. The three main examples where this is happening is going to be with the kidneys, with the heart, or with the lungs, okay? So, because that's where protocols have been established where these organs can be assisted or even substituted, and then we need to make those critical decisions. There are other vital organs, before going into these, there are other vital organs that certainly can be affected and die, but there's as yet no big intervention on those organs from the medical profession. For example, the brain itself, there's no substitute for the brain, and even assisting is going to be through essentially breathing, nutrition, and oxygenation, okay, but nothing directly to the brain itself. Whereas, and also, for example, the liver being a vital organ, very plastic, very dynamic, but at some point the liver can be diseased. Liver cirrhosis can be either from alcohol or from drugs or cancer, but there is really, to my knowledge, no machinery can actually substitute the liver because of the many complex functions that it has. And so on the pancreas, yes, okay, I'll talk a little bit about the pancreas with regards to insulin and a pump, an insulin pump that can replace the pancreas actually. So at that point, it's still a vital organ, but that is definitely standard medical procedure. Okay, let's look at the three main ones. Again, kidney, heart, and lungs. With regards to the kidney then, it's called renal failure, which would be either partial or total renal failure. There's a range there where the kidneys can still work a little bit, but not sufficient to maintain the life of the person, of the individual, of the patient. And so if there is insufficient renal output or insufficient renal filtering, then the standard protocol is to go into dialysis, okay? And dialysis, sorry, there's a little typo here. This is a Y. In dialysis, the blood is taken out of the patient's body, put through a machine and filtered through a machine, and then pumped back into the person's body. Also, I think at some point I had mentioned that it goes out one arm and in the other arm, but today they use the same arm for both out and in, okay? And that makes a big difference because then it frees the other arm for the person doing whatever they want. If they want to read or eat or something like that, or drink, they can do that while they are on the machine. But the important thing is that this dialysis machine is quite sophisticated. As I said earlier, it filters the blood by taking out the toxins, and the toxins are dissolved in water. So it's actually taking out water from the blood and then pumping water back into the system. And that plays with the osmotic pressure of the blood, all right? And that can affect and the heart, it can affect the blood pressure. And therefore, they have to be monitored, closely monitored. You see here the nurses and the assistants monitoring the settings, because the procedure can last 2, 3, 4 hours, depending on how much the patient needs. it's a relationship between weight and age and size and so forth. They estimate how much time the patient has to be on the machine. All right, there's a lot of technicality involved in the background. But because the dialysis machine can alter the blood pressure of the patient, and if something goes wrong with the machine, in spite of the safety systems that it has, the patient could go into cardiac arrest, then the patient has to sign an order every time he or she goes to dialysis to resuscitate or not, to do a resuscitation or not, to get the heart started up again, all right? And that's why there has to be a medical doctor also on call at all these dialysis centers throughout the city. And the center itself is typically a large room with many, sometimes they're beds or recliners, either one, again, depending on the patient, how delicate or vigorous they are, could be the age, they also have a preference, but it's either a recliner or an actual bed for different patients. And the patient also tends to get cold over the hours as the time is progressing because the room is kept fairly cold and so forth. So one other thing that the patient needs is blankets, just in case they start getting cold. They may not be able to put the blanket over themselves just with one hand. So the assistants are there around the clock to help them. The typical regime for dialysis is 3 times a week with 1 day on, 1 day off. And so, for example, if the patient is going Monday, Wednesday, and Friday for, again, an average of about 3 hours, the procedure itself is fairly draining. It drains them from energy. And so what I hear that after some time of being in a dialysis regime, then typically they spend the off day recovering from the dialysis procedure. So I'll spend Tuesday, Thursday, and Saturday recovering. Sunday typically is a day off, but again, it depends on each patient. Sometimes patients are on dialysis temporarily. It could be something temporary with the kidneys that as they recover, or it could be permanent if it's permanent or irreversible renal failure. And some people can be on dialysis for years and even decades and still live. So obviously the medical profession considers this standard of care or standard medical practice. But really for the bioethical analysis, the machine is substituting the kidneys. There's no question that the machine is substituting the kidneys, and therefore there is really no obligation, no moral ethical obligation. One has to go patient by patient. If the patient is relatively young and he is the head of the family and it's necessary for him to continue living to maintain the family, these people do work many times and they take time off from work to go to the dialysis center, but they can maintain a more or less normal life when they're not going through the procedure. There are also, of course, they have to be punctured every time to find a line, to find a feed for the blood, and but they can have a shunt done to generate what is called a port or a shunt with an actual vein from another part of the body or an artery that is implanted so that there's an easy access for those who are in kidney failure. The technicians have an easy access by a shunt or a port. Otherwise, they have to create a line. If for some reason they cannot get a line on the arms, then sometimes it will be the neck or the base of the neck. But typically it's through the arm, or sometimes even in extreme cases, perhaps through the legs if they cannot get a line hooked up to the arm. Anyway, it's a procedure that has some medical involvement, okay? And some patients after a while of being on dialysis get tired of it. Many patients are on dialysis, are also on the waiting list for a transplant, for a kidney transplant. or it can be a combination, kidney pancreas, or sometimes kidney liver. Sometimes, ironically, combination transplants have a better chance because when they have, not everyone is on that combined transplant. There are fewer people who are, let's say, on kidney pancreas transplant. All right, typically people who have had strokes or injuries to the brain, that both the kidney and the pancreas died. But there are fewer of those patients, and when there is a donor, typically a cadaveric donor, in other words, a person who has tragically died by a blow to the head, and that's where the issue of brain death is important, right? When there's typically a traumatic accident to the head, driving motorcycle, precisely young motorcyclists, they are organ donors potentially because an injury to the head, they die, but from the neck down is fairly intact, internal organs are intact, and so they are candidates for donating. That's called a cadaveric donation. At any rate, when the kidney and the pancreas are able to be procured or retrieved together, then obviously that would go to a patient who is on the list, but is for both kidney and pancreas, and there are fewer. So at the end of the day, they have a better chance of getting a transplant. People who are waiting for kidney and pancreas together actually sometimes have a better chance at getting their transplants than someone who is just waiting for kidneys, all right? All right, but I'll talk more about transplantation itself when we get to the healthcare course in the fall. Right, but just as a little heads up, if you will, since we're dealing with the issue right now, is there are in the United States, there are between 90,000 and 100,000 people waiting for a kidney transplant in the United States right now on the waiting list. So it's a huge waiting list, if you will, just by the numbers. And the vast majority, of course, are on dialysis. But this procedure at the very end of the day is an extraordinary means of life support. And so at some point, a patient may decide, no more, I'm not going to do any more dialysis. What happens then is, then it has to shift. The protocol has to shift to caring for the patient. There's no more cure, all right, and a transplant has not shown up. And so there's no more cure for this patient who is a renal failure, which means that their kidneys will continue to shut down. Eventually, they will be intoxicated with the toxins of the body, and that will cause other organs, other vital organs of the body to fail, the heart, the lungs, the liver, and so forth, the brain. And so the standard of care there is to shift to care, precisely care of that patient who is now dying actively. Hospice comes in, and it's a matter of time. It could be a few days, a few weeks, maybe a month, but that patient on renal failure will die. And so at some point there's going to be pain involved, and therefore morphine and analgesics to manage the pain. And that's where it's very important not to kill the patient, but to manage the pain, right? So it will come down to the dosage, the actual dosage that is being used in the morphine or an analog. If a person is allergic to morphine, they'll use some other chemical that has the same, essentially the same active site without causing the allergic reaction. Okay, so you see when there's no more cure, care, it always obligates, and care kicks in to maintain the patient as calm and pain-free as possible. Let's look at another issue at the end of life is the lungs. It could be emphysema, it could be a number of issues to the lung, either illness, cancer, or it could be trauma to the lungs, an accident, right? But we have to make a distinction here, critical distinction between a respirator and a ventilator, okay? Because the respirator typically assists in providing oxygen to the lungs. So a respirator is a simpler machinery, right? It typically assists in providing oxygen to the lungs, and I'll show you some examples. Whereas the ventilator is a more sophisticated machine. Typically, it's a tube into the lungs, and that ventilator can either assist or substitute the breathing depending on the settings, on how much oxygen is actually being pumped in by the machine. Okay. So we're making a distinction here between a respirator and a ventilator, which is a clinical, technical distinction.
The ventilator can either assist or substitute?
Yes, depending on the setting. I'll show you an example, I'll be more specific in a minute. Let's look at the respirator first. Here are some examples of respirators, and it's very obvious that it's totally external, whether it's a simple little tube to the nose, to the nostrils, the tube to the nostrils that is supplying oxygen, but the lungs are doing the breathing themselves. They're just being supplemented with extra oxygen, okay? Or it could be a loose mask to the face, including the nose and the mouth, so that this patient, maybe the patient is unconscious or semi-conscious, may breathe either through the nose or through the mouth. And so it covers both, but it's a loose setting. In fact, there are little ports here on the side of the mask to let in normal air from the environment, in addition to the oxygen that is being supplied directly. But it is definitely assisting because the lungs are still doing the bulk of the work here, are doing all the work. This person is still breathing on their own, okay? There's a third type of ventilator, respirator, that is even a little more sophisticated, but it's still a mask, but the mask is tightly secured around the face and the mouth. And this one is a little more elaborate. The first thing that happens is that the person may have the sensation of asphyxiating, because this mask now is going to be tight over the nose and mouth of the patient. Okay, so their conscience is very important that the settings are proper and there's a constant flow of oxygen here. Otherwise, the patient is going to feel like asphyxiating, lack of air. Okay. But even as this is a tight fit around the mouth and the nose, it is still really just assisting because there's not enough pressure in this oxygen flow as to force the lungs to breathe fully, all right? So this is still assisting, and that's why it's called a respirator. It's assisting in the respiration of the lungs. It's complementing. Different is a ventilator. A ventilator is actually a larger machine and typically ends in a tube that will be inserted through the patient's mouth, down the throat, down the trachea, into the lungs, all right? And this intubation is done with a clinical procedure, and so the ventilator is a more sophisticated machine. Essentially, inside here, there's like a pump with a cylinder that moves up and down and can actually cause pressure. It can pump in air under pressure, okay? And so that pressure will now inflate the lungs from the inside out, all right? So it is opposite functionally. It is different from the ribs and the diaphragm, in that the ribs and the diaphragm are expanding the lung from the outside, and therefore the lungs are sucking in air. This one functionally is the reverse. This one is actually pumping in air into the balloon, precisely because the other system is not working well, all right? And so this one is forcing air into the lungs to expand it. And then, of course, a few seconds later, it has to allow that air to come out, right? To be expelled, to exhale. And then it also filters out the CO2 so that the CO2 is not pumped back in with the next breath. The point about the ventilator is that depending on the setting, all right, what kind of setting, the percentage of perfusion, or the percentage of air that is being pushed in, is either assisting or substituting the lungs. And globally, the cutoff point is going to be about 2/3, about 70, 75%, more or less. In fact, there is a weaning process that begins very actively. The weaning process is as soon as a person is put on a ventilator, the technicians, and let's say that they start at 100% initially. 100% meaning that the ventilator is doing all of the work. The ventilator is pushing air into the lungs and making the lungs expand and contract 100% by that pushing of the pressure of the air, okay? So the initial setting, let's say, is 100%. Immediately, the technicians start a weaning process. In other words, trying to extubate the person, trying to reduce the settings to see if the lungs of the patient will start reacting and start taking up some of their normal function. So they'll go down to 98%, 95%, 92%, 90%. And if they see that there is not enough perfusion is the amount of oxygen that is getting actually into the bloodstream, okay? And that can be measured by this little dial on the finger. This little clamp that is put on the finger measures the amount of oxygen that is in the bloodstream. It's very sophisticated, and I think it's done through, it's some kind of biochemical or electrical activity that is occurring at the fingertips that allows the technicians and the medical profession to determine how much oxygen is actually in the bloodstream, okay? Also because it takes about 30 seconds for the bloodstream to circulate through the body. So it's a fairly fast return. From the heart going out and back to the heart is about half a minute. And so they can determine rather quickly how much oxygen is actually getting into the bloodstream. And if it's below, they want to keep it, of course, the optimal is 100%, but up in the 95% of, it's called perfusion. I think it's double S. Maybe one is. Passage of fluid through circulatory system, but this particular case is down to the capillary, and specifically the blood, the oxygen in the blood. Let's put, okay, let's see perfusion pressure. Maybe oxygen. Oxygen perfusion, there we go. Yes, the exchange of oxygen and CO2 in the bloodstream, and this is able to be detected with this little machine. There was something on vents here. Oh no, it's much. Let's see if it has. think it's the same thing about the fingertip. Oh, no, these are the actual machines. Okay, well, you can see there the setting 98, 99% perfusion, that's the standard. It also picks up blood pressure, of course. But that's the percentage of O2, of oxygen in the blood. Anyway, with this little finger cap, all right, the technician is able to determine how much oxygen is actually going into the bloodstream. And that's how they regulate the setting. But this weaning process is a standard now when a person is intubated to try to extubate as soon as possible. At the end of the day, a person normally can be intubated through the mouth for up to 2 weeks. 3 weeks is really pushing it too hard, all right? But beyond 2 to 3 weeks, there would be permanent damage to the vocal cords and also to the throat as a whole. And therefore, at that point, typically the 2 to 3 week window is when the decision has to be made. If the patient is going to continue on the vent, then the doctor has to do a tracheotomy and go through bypassing the throat down at the base of the neck directly through the trachea, into the trachea and down into the lungs, okay? That requires surgery. It's minor surgery, but it's a surgery that can have significance, ethically speaking, because once a person is intubated through the trachea into the lungs, they can be maintained there for years. And they can be on vegetative state for years and years, essentially. They're stabilized, but we have to ask the critical question, is the patient dying or not, right? Are the organs failing or not? Because they can be maintained there indefinitely. So there's that window between 2 to 3 weeks. If the pneumonia or whatever illness or disease is affecting the lungs has not been cleared, then a critical decision has to be made there within a couple of weeks. All right, extubation is pulling out the tube, and at that point, either the patient breathes on his own or not, all right, at the point of extubation, and that's the critical moment. Okay, I mentioned that beyond 2 to 3 weeks, it's no longer possible to maintain the tube through the mouth and going through the throat. And so bypassing the throat is a tracheotomy, is the surgical procedure to put the tube through the, right into the trachea directly, bypassing the throat up here, and thus having direct access into the lungs. The hole itself is called a tracheostomy, all right? That's the whole stoma is opening or mouth. And some people can live with a tracheostomy and be extubated later, recovering from whatever illness or disease they had. A typical one is the pneumonia. But when they recover, then they can use any kind of a scarf or filter that is put at the base, at the opening of the hole itself, the tracheostomy, so that air particles in the air, even small particles, don't have direct access, because that can irritate and actually can choke the person. All right, so particles that are in the air that can get in through the hole, through the tracheostomy, because no longer is the person breathing through their nose, and no longer is that air being filtered and cleaned through all the sinuses and all the mechanisms that we have for cleaning air in the upper respiratory tract. Okay. So typically the person will use a scarf or a bandana or something. Sometimes they use actually a mask on top of the tracheostomy to keep it clean. And they have difficulty speaking. Sometimes they use a machine that they put on the side of of the throat here at the larynx, which is the vocal cords, and that machine translates the vibrations into a sound. It's a little awkward. Depending on what degree of damage they have in the vocal cords, they can actually talk or not. It's a whole range of inability to be able to pronounce words. Okay, so the vent then, depending on the setting, is either assisting or substituting the lungs. If it is assisting, then it obligates, at least temporarily, while the patient recovers. That would mean that the prognosis is a good, positive prognosis. But if prognosis is very poor and there's really no hope of recovery, the settings may be substituting, the vent may be substituting the lungs, and they no longer obligate morally, ethically. The person can be extubated and allowed to die in peace. Of course, typically the person is sedated because they're going to have the sensation of not being able to breathe, choking to death, and therefore the person is sedated so as not to feel that anguish of lack of air. And therefore, any pastoral healing that is going to be done and anointing and so forth has to be done before the sedation, because the patient is going to be put out. Okay. Last rites, exactly. Yeah. And also for the family, it's very important at that point, pastorally, to talk to the family members, whoever is around, what is happening, and that make that distinction for them that at this point, there's no hope of recovery, the cancer is too advanced, is not responding, and the ventilator is actually substituting the lungs, the vital organ, and there's no obligation to continue that substitution. At that point, they're actually prolonging the death process of this patient. Yeah. Okay, the third one is the heart, of course. The heart is definitely a vital organ, and the heart can stop. That is a heart attack, that is a cardiopulmonary arrest, right? Cardiac arrest. And the procedure for getting that heart started again is known as cardiopulmonary resuscitation, CPR. This may assist or substitute the heart, again, depending on a number of conditions of the patient. Here again, we have to go patient by patient. So, for example, if it is a relatively young person and who has a heart attack all of a sudden, if someone can do CPR, generally it could be considered assisting that heart in starting up again, and there's nothing that is known wrong with the patient. But these compressions that are done on the chest by CPR are pretty strong compressions, because it's generating artificially what the ribs do normally, all right? But the ribs are not reacting and the diaphragm is not reacting either. Well, actually, I take it back, it's trying to stimulate the heart itself going through the rib cage. And so it's pretty traumatic for the rib cage. And what I'm trying to say here is that sometimes for the elderly people, since their bones are more brittle, they have lost calcium over the years and the decades, the bones are more brittle. Many times doing CPR on an elderly person will break the ribs, okay? And some of these broken ribs can actually puncture the lungs underneath and cause a hemorrhage and other complications. So CPR on an older person is a more delicate thing, and it has to be thought over. So in that particular scenario, it may be that the CPR is an extraordinary means of life support. In other words, the heart has stopped for whatever reason. The person has gone into cardiac arrest, a heart attack, and we may allow that person to die in peace. It may be that there is no obligation to get that heart started up again, okay? Again, if the person is elderly, it may break the ribs and actually complicate their medical scenario worse than just a heart attack. Had a heart attack, the heart stopped, it's a vital organ, the person is dead, right? It's the cardiopulmonary criterion. Once the heart stops, very soon the lungs will stop breathing also. And so they go hand in hand. An alternative to the CPR was actually CPR, but instead of doing compressions is a defibrillator. There's even one across the hall here. There are now defibrillators in different public settings. But basically, it has to do with people who have arrhythmias or dysrhythmias, that their heartbeat is not a rhythmic heartbeat, all right? And it could be spontaneous or it could be a chronic condition. A couple of them are this ventricular fibrillation, where there is some spasms of the heart, the ventricle, which is the pumping side of the heart, the lower chambers, and the larger chambers of the heart. Or it can be a tachycardia, which again is some kind of spasms of the heart. Either way, this can be treated actually by or put back into a normal rhythm, a normal heartbeat with a defibrillator. And the defibrillator delivers a dosage of electric current across the heart. And you see the pattern here is put like this, generally, so that that current will flow through, and it's a pulse of current that will flow through the heart to try to get it started up again or get it back into the normal rhythm, the normal heartbeat of 60, 70, 80 beats per minute, whatever the pulse is. So again, depending on each particular patient, whether this is going to be assisting or substituting the vital organ of the heart. But the general inclination would be toward substituting, because if the heart stops naturally, then it's a natural event, it's a natural phenomenon. Yeah, it's a heart attack and it's drastic and it can be fatal, but generally there may not be an obligation to start up that heart again. Okay, we're coming toward the end here, and we can ask the vital question: are we killing the patient or are we allowing to die? And I can tell you, and I'm sure you've seen this, excuse me, also in the pastoral ministry, that sometimes it's difficult to determine if the patient is actually, if we are extending their life or if we're extending their death, right? And so the main focus is on the vital organs, any one of the vital organs. If that vital organ is failing irreversibly, then the death process has begun. Even if that death process is subtle and there are not too many symptoms, all right, then the death process has begun, and we may allow that person to die. Again, what happens there is a shift toward palliative care, toward comfort care. Different, of course, is killing a person actively, which would be with an overdose of morphine or other chemicals that will literally put the person to sleep, as we say, but it's actually killing the person. It's important not to cross that line. And so there has to be a good, intense and honest dialogue with the medical profession, with the family, the wishes of the patient. There's a subjective element here also that we need to consider, that one patient may feel that this particular protocol is, they can tolerate it fine and they're willing to go through it, again, like dialysis, but another patient may consider that that same protocol in their particular condition is an excessive burden. Exactly, it's an excessive burden, and there is a subjective estimation here that has to be respected. Of course, if the patient is not being realistic about their subjectivity, in other words, about their not wanting to receive a treatment, that is a relatively standard treatment, we can try to convince the patient that it's for their good. Again, the one typical one would be in the ventilator, the case, a person with pneumonia that needs that vent for maybe 1 or 2 weeks with a regimen of antibiotics to overcome the pneumonia, but the patient has a good prognosis, he has a good hope of recovery. We can try to convince that patient to give in to being intubated, right? But there may be a patient that considers that intubation is totally extraordinary and subjectively doesn't want to be because they have to be unconscious and so forth. They don't want to go through that. To them, it's an excessive burden, subjectively speaking. And we could try to convince them otherwise, but at the end of the day, we have to respect that opinion. We have to respect on it. And in fact, I keep forgetting to bring a document. I'll get it for you in the next few weeks, which is the Ethical and Religious Directives for Catholic Healthcare Services. And this is the Catholic teaching. It's a document that went to the Vatican, has been approved. It's in its 5th edition already. And it mentions there that in the subjective estimation of the patient, if the patient considers this particular procedure, whatever it is, an excessive burden, then the patient has a right to refuse that procedure. So there's a lot of subjectivity involved in that statement, all right? It's a lot of leeway. Okay, so that's basically the end of this part. When I get that document, we'll go over it and you'll see the different directives and points that are there. They're very specific, referring to particular cases. And it's very useful because, again, it has the approval of the National Conference of Catholic Bishops, and it has the approval of the Vatican. So that is basically the official position of the Catholic Church in this beginning of life and end of life issues. Okay. Okay, well, if there are no other questions, that's what I have for today. Ended up a little earlier. So once again, we'll meet next week for continuing. And I'm adjusting the schedule a little bit because the last Saturday of April, I have to be out of town and therefore we won't have a class. And then I have to turn in grades. So yeah, the last Saturday of April. So I'm moving the schedule up a little bit. And then also we have Holy Saturday there, the last Saturday of March, yes. Okay, so 2 days of no lecture coming up. One this month, the other one next month.
Thank you very much.
Okay, you're welcome, and thanks again for listening, being here. For those of you who were unable to come, then you can watch the video. I'll have it from this afternoon forward. Okay? Bye-bye now. All the best. Bye-bye. Thank you. God bless you.